Okay, so we're going to be talking very quickly about cervical stabilization, and I have my patient already set up. We are looking for the ear to be parallel to the table, so you're going to either raise or lower the towel to make sure the ear is parallel, because that puts the neck in a nice position where she's not too far back so that her neck is being overstretched, and not too far forward where she feels her chin is collapsing into her neck. What we're going to be doing is we're going to be activating the deep cervical flexors. And so I'm going to place this blood pressure cup underneath her neck here. Okay. And I made sure that the bladder was kind of folded in half and the prickly side is facing down so it doesn't prickle her neck, because that's not nice to prickle your patient's neck. Okay, from there I'm going to pump it up to 20. And this is going to take a bit until the bladder all the way inflates and supports her neck there. And sometimes I'll wiggle the bladder a little bit just to make sure, so you can see that it went down a little bit. Okay, now we're ready to begin cervical stabilization. So I am going to make sure, again, that we are activating the deep cervical flexors. So if you imagine her spine here, if we activate the deep cervical flexors, they are on this side, unpalpatable, and they are going to flex the spine, which is going to flatten the cervical lordosis. Okay? So in order to do that, I can't really palpate it because that's under her trachea, and that would be uncomfortable for her to actually palpate that. So instead, we're going to use process of elimination. Normally, scalenes and sternocleidomastoid perform cervical flexion, and so if we are not contracting scalenes and sternocleidomastoid, then she must, by process of default, be contracting deep cervical flexors. So I'm going to palpate right along sternocleidomastoid and scalene. So when she does this activity, I'm going to make sure that she is not activating these muscles. Just be careful with your hand placements. You don't want to be like strangling their neck here as you're palpating to make sure that she is not actually substituting. From there, the verbal cues. You can use a couple of different verbal cues. You can use a slight chin tuck with a pull or like a string attached to the top of their head. Sometimes patients respond to the sensation of their neck is getting taller. You could use the verbal cue that someone is getting too close to you, or you're too close to the mirror and you're backing away from it. Either way, what we're going to do is we're going to chin tuck. So while I'm palpating, she's going to tuck her chin just slightly and elongate her neck. And it's going to flatten out and increase the pressure on the dial. Now, if it goes above 30, we know we're probably getting too much of scalenes, and she's got a little bit of activity, so lessen up on the push there. Okay, and we should be in between 20 and 30. And relax. Okay, and you see it drops down just slightly. So now I'm going to have her hold this for 5 seconds, and I'm going to continue to palpate her, and I'll have her do reps and sets until I feel like she's kind of got it. From there, we can start moving the upper or lower extremities. It's going to be much harder to stabilize the neck while moving the lower extremities than it will be to stabilize the neck moving the upper extremities. Again, start in an out of plane motion and then work towards flexion or extension bias depending on the pathology the patient has. The blood pressure cuff can eventually be given to the patient so that she could potentially hold it and get biofeedback on her own.